So thank you for the opportunity to speak. I just have some disclosures here, really unrelated to this talk. I have a number of slides, so I'm going to go fairly quickly with a number of these slides. But with this slide, I really just want to point out that other trials in ocular oncology that were prospective, that were well designed, ended up making us understand with significant clarity fundamental questions in ocular oncology that could not be answered with retrospective data. And in the field of retinoblastoma, there is absolutely no shortage of questions that really cannot be answered without a well-designed prospective trial. And there are many questions that are here that a number of researchers back and forth discuss and argue, in part because, as has been pointed out, so much of our data is retrospective in nature. And there's a lot to learn from retrospective data, but there are significant limitations for doing so. In fact, I recently reviewed a manuscript that said there have been no prospective trial, multi-center prospective trials in retinoblastoma, and I had to disagree. So I'm going to talk about the Children's Oncology Group, and the first question that comes up is, well, what is the Children's Oncology Group? Because many people outside of the U.S., and in fact many people in the U.S., have never even heard of the Children's Oncology Group. So Children's Oncology Group is really a collective. In 2001, there were many collective groups within the field of pediatric oncology in the United States that were independently funding various prospective trials in pediatric oncology. 2001, they came together. They actually had a retinoblastoma subcommittee that was developed by a leader in the field, Anna Meadows, who was at CHOP for many years. Some of its strengths: it has a track record of supporting clinical trials in pediatric oncology, and significantly, in addition to the entire infrastructure that you need for these sort of trials, it has funding and support from the national government, from the U.S. national government. It has had already, since its establishment, many successes, including bringing together, as Dr. Singh pointed out, the multiple disciplinary groups that are necessary for any trial related to retinoblastoma, because it is truly a multidisciplinary disease like many cancers are today. There have in fact already been 5 clinical prospective trials that this group has already opened, and 4 of which are closed. The only one that is currently open I will speak about is the intra-arterial protocol. The first one I'm going to spend a little bit more time discussing, and then the other 3 I will quickly go through. What I would like to point out most significantly at these are international trials. 2 of the 5 were international, and 1 of them had significant support from India. So this is the main trial that was highly successful in recruitment. This was a unilateral trial looking at the role of adjuvant chemotherapy in the setting of high-risk features, high-risk histopathology. And the schema of this trial was basically unilateral disease that was enucleated, defined either to have high risk or not high risk histopathology. Those with high risk received chemotherapy, those with not were observed. And one of the most fundamental things that whenever you do a prospective international trial is you create a standard for defining certain features. So this trial, even though there had been many papers that talked about high risk histopathology, gave some specific definitions: massive choroidal involvement, any posterior uveal involvement with optic nerve involvement, and optic nerve involvement posterior to the lamina excluding optic nerve disease. And you can already see these definitions were then incorporated in part in the group, in the 8th edition of the AJCC. So here's some pictures here from histopathology. You all know them. But I think the most fundamental aspect of this is the definition of massive histopathology. Choroidal involvement is this definition of 3 millimeters of disease. So 3 millimeters of choroidal involvement in any direction is considered massive. And I think, again, it's very nice to have a specific definition that people can go to. One thing that prospective multicenter trials do that retrospective data doesn't do is central review. So there was a central histopathologic review of every specimen that was sent out in this trial, and 3 world's experts agreed as to whether these cases had or did not have histopathologic review. So the center.
So this is very important. So these people who are reviewing don't know what has been.
They're blinded to the data, and so every center may have said this patient does or does not have high-risk histopathology. but based on treatment or not, it had to be reviewed by these three experts, and two of the three had to agree. And these were Patty Chavez-Barrios, Ralph Eagle, and Dan Albert, truly leaders in ophthalmic pathology in the United States. So there are things I can tell you about the trial, and there are things I can't based on rules of COG. So there is more information, but I cannot describe it until it's published. That said, I can tell you that this trial accrued. It accrued in part because nearly 1/3 of patients came from the Republic of India. The accrual was from 2005 to 2010, and 312 patients were reviewed. An interesting thing is, if you look at the histopathology, a fundamental decision-making process, 49 patients had their classification changed as a result of histopathologic review, which means in 13% of cases, the local center said they did not have high-risk features when, in fact, central review said they did, and 24 the other way around. Again, showing you that even centers that deal with retinoblastoma aren't always focused and able to arrive at what a central review would. Again, something you're only going to get in a prospective trial, not from a retrospective paper review. So there are already some preliminary conclusions demonstrating the role of central review. There were really few complications with those that did receive chemotherapy, and more data will be coming within the next year because a paper is in the process of being submitted. The other trials that were open and closed, I'll briefly go through for time considerations. There was a Group B trial. These patients, they tried to only give 2 agents of chemotherapy and then focal treatments, carboplatin and vincristine. This was the schema, 3 cycles of carboplatin and vincristine. The trial was closed because of the definition of failure. Failure was the need for any additional chemotherapy or radiation. So there were eyes that were salvaged, but again, a prospective trial has strict definitions. And because there were 5 patients that, quote, failed, even though the eyes were successfully salvaged, the trial had to close based on rules of the trial. The Group CD trial looked at intensifying chemotherapy with periocular chemotherapy when that was very fashionable, let's use that word. And patients were given a higher dose intravenous chemotherapy, periocular, carboplatin, and this trial was also closed in part because accrual was slow. And we think it was in part because there were a number of centers that were not as enthusiastic about periocular chemotherapy. And there's certainly some challenges with periocular chemotherapy, and partially because other modalities like intra-arterial and intravitreal began to gain hold. So there was a slow of accrual, and COG closed this trial down. Perhaps more significant to this audience is the 0321 intensive therapy for extraocular disease. Again, something where international collaboration was key. And there were centers in Latin America and Africa that helped provide a role here. And here, unlike the others, this goal of this trial was really on patient survival. And so they used intensive systemic chemotherapy in the role of stem cell harvest, autologous stem cell rescue, and then in certain cases radiation therapy. And this used a staging system by Chantada that was described in the previous talk. And so all these were eligible, but they received different treatments, especially 4A versus 4B, obviously much more significant if you have CNS disease. This trial is closed. It achieved its target accrual, but we cannot make any statements yet. The data will be coming out. Finally, I'd like to talk about the only prospective multicenter national trial in the United States for intra-arterial chemotherapy. We'll hear more from our colleagues from Memorial Sloan Kettering. But in my opinion, and in the opinion of some, there are still many unknowns with intra-arterial chemotherapy, particularly long-term potential damage to the ophthalmic artery, which is why some centers in the United States will not do any intra-arterial chemotherapy for fear of these unknown toxicities. And I would remind you that in the era of external beam radiotherapy, we treated patients for decades without knowing that we were in fact increasing their risk of radiation-induced tumors. So we should not underestimate unknown risks. We certainly know that there are things with intra-arterial we have not seen prior to the role of intra-arterial chemotherapy. This is the hyperrefractive particles that have been seen by some of our ophthalmic pathologists. This trial looked at the feasibility of injecting melphalan within the context of a multicenter trial. Its goal was really to look at the ability to do so, and then its secondary objectives were to look at toxicities, adverse effects, and the feasibility of doing so in other multicenter trials that we were planning in the future. Basically, children have to have unilateral group D, and we have a distinct definition of group D for the purposes of this trial. They're given a single-agent intra-arterial melphalan with a dosing regimen that was assisted with members from the New York group, and a dose modification depending on the significant variation in the vasculature, and I'm sure our colleagues from New York will discuss that a little bit more. So again, a prospective trial through COG has very strict stopping criteria. You will not get that in retrospective data. So here, instance of stroke, death, we know that strokes can occur. This has been presented at meetings already. We know central retinal artery occlusion can occur, and we know there can be significant risk for femoral artery occlusion, particularly in patients who are very young, generally less than 6 months of age, which is why this trial only allows for patients 6 months of age and greater. Again, critical theme here, central review is a significant part of this trial, not only for chemotherapy but also radiation exposure, and all ocular pathology, if a patient succumbs to enucleation, will be reviewed by central review. Again, the same mechanism that was so successfully used in the other trials. So in conclusion, there really has historically been very few other groups that have successfully pursued prospective multicenter trials in ocular oncology in general, but certainly retinoblastoma. COG has the infrastructure to do that, which is generally the limiting component for many individuals wanting to move forward with multicenter trials. There have since already been 4 trials that opened and closed, 2 that met accrual and 2 that did not. And there are 2 manuscripts that are already in preparation. There's already one that was published by Dr. Chavez Barrios and colleagues on the histopathology. And at present, the group is the only U.S. multicenter prospective trial for intra-arterial chemotherapy, actively recruiting at 6 U.S. sites and expanding to 2 more to be a total of 8. And I just want to reiterate some of the things that Dr. Singh had sort of mentioned. You know, you have to be able to collect data prospectively. You need that's the basis for any future trial. This is already therapy, but if you don't have data to begin with, if you don't have the ability to start with where we have, you know, where's the beginning point, then it's really difficult to set up trials and to have people say, okay, what is the next step? Where do we want to move forward? So I applaud Dr. Singh for you know, wanting to move forward with a mechanism to at least simply look at data, because without that data, no one is going to know are we getting better or worse. And in fact, that's a big challenge in the field. Thank you. I'll take any questions if you have them.